Good afternoon and welcome to the California Department of Public Health and California Medical Association's virtual Grand Rounds. I'm Dr. Shannon Udovic-Constant, a San Francisco pediatrician and also CMA's immediate past president, and I'll be your moderator for today's session, The Evolving State of Public Health Vaccines, Advisory Groups, and Other Emerging Issues. The goal of this series is to highlight pressing public health concerns across California and provide timely education to support our healthcare community. We are especially grateful to Dr. Erica Pan, who's an MD and an MPH, for joining us today, despite her very busy schedule in her role as Director and State Public Health Officer at the California Department of Public Health. She continues to make time for these important conversations. And today she'll share updates on infectious diseases in California and other CDPH priorities. Following Dr. Pan, we'll hear from Dr. Rita Nguyen. Next slide, please. So you can download today's slides and follow along. Instructions are provided here. Next slide. Here are our speakers' disclosures for today. Next slide. This series is accredited for CME credit, and after the webinar, you will receive a survey where you can attest to your attendance. Once completed, your CME certificate will be emailed to you. And now it's my pleasure to introduce our speakers today. First, Dr. Erica Pan, who is the Director and State Public Health Officer for the California Department of Public Health, a role that she assumed in February of 2025. She brings extensive experience in infectious disease control, public health emergency response, and health equity. Prior to her current position, Dr. Pan served as CDPH's Deputy Director for the Center for Infectious Diseases and as the state epidemiologist. Dr. Pan is a clinical professor of pediatric infectious diseases at UCSF and continues to practice at UCSF Benioff Children's Hospital. Joining her is Dr. Rita Nguyen, and she is the Assistant State Public Health Officer at the California Department of Public Health. In her current role, Dr. Nguyen supports the State Health Officer in addressing pressing and emerging public health issues. She leads CDPH's Population Health Pillar, which includes oversight of the Center for Environmental Health, Center for Healthy Communities, Center for Family Health, and Center for Health Statistics and Informatics. Prior to this, she served as the Assistant Health Officer and Chronic Disease Physician Specialist for the City and County of San Francisco's Department of Public Health. And now I turn it over to both of you for today's presentation.
Great, thank you so much, Shannon. It's nice to be here again today, and I will just jump right in. There's a lot going on in public health right now. Let's go to the next slide. As far as some key areas within evolving public health, we wanted to talk a little bit about what's happening with the public health climate, what we're doing in California to sort of try to meet this moment and strengthen our partnerships, a little bit about respiratory virus updates because it's relevant to some of the evolving changes and of course this upcoming season, and at least one other brief touch on Mpox Clade 1, which we've now seen in California. And then Dr. Nguyen is going to talk a little bit more too about some of our other chronic disease issues and other things, and where we are seeing some lights and progress as well. Next slide. So a lot of things are happening in this year, over this past calendar year, related to our federal environment with public health. And these are just sort of some summary areas. It is very complicated and continues to evolve quickly, but organizationally, there have been a lot of key offices, program staff, leaders at the CDC and other federal offices, even before the current federal government shutdown. Probably close to 30% or so of the CDC has already been either cut or workforce loss due to attrition or other things. So a lot of key areas there. And with that comes a lot of loss of experienced leadership and a lot of subject matter experts who have been, dedicating their careers to some of their expertise in some of these areas and work. And as many of you know, and we'll talk more about this, there's been dismissals and or replacement of very key advisory committees that many of us as clinicians and policymakers, rely on to help make public health and prevention recommendations. There's of course a lot of areas of concern relating to data sources being pulled down, data fields being removed, surveys either not being funded anymore or being removed. Some of those things have been up and down over the last year as well. And then certainly of course concerns about data sharing beyond intended use. There are certainly many things where we certainly within state government and public health absolutely keep our HIPAA and sort of public health investigative data privacy, and we're learning more about different systems at different levels that can do data sharing, maybe not for the intent that we all have of serving our communities. And then of course on that note, I think just of course a lot of the policies have really led to a lot of concerns about community safety, our individuals and communities feeling like they belong and their actual existence. If you remove a data field about a person, it makes them feel like they don't exist anymore and that they don't belong. And that's of course led to a chilling effect on a lot of different services as well across the board. And then on top of all of that, as far as funding, I think it's really important to make sure you all realize that 80% of the CDC funding actually goes to state and local health departments. So while some may think, oh, well, if it's federal government, sort of funding cuts, that's a federal government thing. But actually, again, 80% of that funding at the CDC goes to our communities. It's sort of broken up into and how we're kind of monitoring and reacting to. There are the mandatory funding things that happen. So HR1, which has primarily been impacting Medicaid, and the SNAP CalFresh nutrition services. And then for us specifically, the SNAP Ed cut pretty much decimated our nutrition and physical activity staff within public health. So while there's been a mention of nutrition and chronic disease to be a priority, that is not matching sort of where the resources are going. And then the most of this funding that I'm referring to that comes through the CDC to state and locals is actually in the discretionary budget. So it's all still tied up in this federal budget process and the appropriations process right now that is under deliberation, and there's very different budgets coming out of what the initial federal administration presidential budget proposal versus the House and the Senate. All three budgets look very, very different. There are significant cuts anticipated, but what those actually cuts are going to be is still unknown. We're certainly tracking that closely as well, but it's been challenging to know what will really happen there. And then there's been other things that happen, such as things they're calling pocket rescissions, where even if it's not agreed upon in the appropriations, there are other ways the administration has been trying to pull back funding. The key example of that I'm sure is on many of your radars is with public media, public radio. That was how those funding cuts were made, so outside of appropriations. And there's concern that that could happen in other areas as well. So at the state level, it's also important for you all to know that almost half of our state health department budget is actually federal, and 2/3 of our entire budget goes to local assistance. We've had all kinds of grant delays, terminations, restrictions, changes in requirements. There have been stops and starts of even pulling down funding. So there's been a lot of challenges there. And then at the state level, you likely have also heard that our state budget also has a huge budget deficit projected. Next slide. So all that is daunting, but I do feel incredibly privileged to be in a state like California where we are doing other things. Next slide. To try to strengthen our partnerships and step up. So you may have recently heard about a larger national Governors Public Health Alliance across 15 states. And then I think in our last CMA Grand Rounds with all of you, we did mention the West Coast Health Alliance had just been announced. We've also just launched at the end of September a new coalition that I definitely want many of you to join if you haven't already, and I'll talk more about that. It's a fact coalition to help us promote and distribute the facts, but public health health for all Californians together. And then really importantly, in mid-September, we were able to update our California laws to protect evidence-based vaccine recommendations, access, and coverage. So I'll talk about all of that. Next slide. So kind of working sort of national down to state. So the 15 states that have joined a Governor's Public Health Alliance, it's a non-profit coalition of governors that is working together to protect public health. You can see which states both on this map and on this list here. And, you know, some of the overarching goals around this are to strengthen our overall public health and emergency preparedness, be able to share data and expertise across our states, enhance cross collaboration, and really serve as a forum to discuss best practices and common challenges. And this is a really nice alliance that's happening across the governor's offices, their governor health leads, and across departments like ours as the state health department to work together. And, you know, there are many different ways we all work and collaborate across our states, but this is a nice way we're starting to formalize this and also think about issues around global health as well, as we also have concerns. Actually, I didn't put in the prior slide that, you know, there's also the withdrawal from the World Health Organization and really anticipating what will that change look like and how can a subnational group work together to anticipate and prepare for that. Next slide. And then the West Coast Health Alliance. So as far as our purpose, you know, again, this is our California, Hawaii, Oregon, and Washington. We are building this on prior partnerships and both formal and informal collaborations in the past, but we really, our goal around this is to uphold our integrity of effective public health strategies to protect our communities. We are collaborating on review of the best available science and evidence to make unified recommendations and largely relying on other national professional organizations to do that, especially to, again, reduce confusion as much as possible. And we want to support safety, efficacy, transparency, access, and trust. So we're working together across our West Coast states to ensure the public has access to credible information that we're aligned on. And again, trying to reduce confusion. And it's one of many ways we're trying to increase trust in public health and counter some of the confusion and misinformation out there. And again, working on having evidence-based position statements, policy recommendations, and guidance. And as I mentioned, seeking alignment with national medical professional organizations, especially because many insurers and others would like to have that consistency. And we're not trying to make a new West Coast thing as much as possible. We're really trying to align with other national standards that we do trust. And of course, sharing tools and best practices along those. I think I also wanted to mention here that the members of the West Coast Health Alliance are really largely the governors, and then officials like myself and within our departments, subject matter experts within our departments to work together. And we have oversight and direction from our governors to work on these things. But it's really different than when we created a Western States Scientific Safety Review Work Group during the pandemic, where we brought in other experts from these committees and had other external members working together. Again, we really want to rely as much as possible on those national organizations to help make sure there's alignment across the country. Next slide. And we've agreed upon some shared principles here. You know, I've sort of said much of this, but health is a right. We want to promote science and integrity. We're working on, you know, promoting transparency and trust in our public health responsibility, and of course, continuing to promote equity. We're also recognizing tribal sovereignty in all of our states and really wanting to make sure we're doing everything we can to promote coverage and access to important preventive health services. Next slide. So our scope is, again, responding to threats to national policies and recommendations. If there are, again, committees, you know, we talked, I think, at the last meeting about the Advisory Committee on Immunization Practices was terminated and then rebuilt. There are other advisory committees that we have all relied on historically that have been compromised in different ways or completely terminated. So again, we want to review other credible clinical and scientific professional organizations to assess changes in public health policy and, again, developing some unified policy recommendations and, again, trying to address communication needs. Some of the initial areas of focus here are going to be, as you've seen from us, immunizations. And then many of you maybe also know that the Healthcare Infection Control Prevention and Practices Committee was also dismantled. I'll touch on that a little bit later on what's happening in that space. You know, there could be things if there are FDA authorization regulation changes, which certainly happened in the vaccine space, but there's some overlap there, and then other preventive services guidelines. So currently the U.S. Preventive Services Task Force seems to be intact, but there have been some threats to that as well, and this would be a forum to have some alignment in that space as well. Next slide. So shifting gears a bit, here in California, the other thing we have just recently launched, also early stages, and but really excited about building a coalition here in California that we're again calling Public Health for All Californians Together. And we really want to build trust and strengthen community well-being by improving health outcomes, and again, evidence-informed services and care for Californians. And this is really to bring together a network of people and organizations across different health sectors, community-based organizations to share anything that we're coming out from the state health department, and also helping work with partners to have culturally appropriate health messaging and actually get bi-directional feedback and hear what are the questions and concerns or implementation barriers that our different communities are seeing as we work to protect the health and well-being of Californians. Next slide. So the kinds of organizations, as we move to the next slide, you know, everything from our state health department as kind of leadership of this, and let's go back one, and then local health departments, and then I'll just mention briefly and then talk about the other circles on here, but two main organizations that are really creating a triad to help lead this and operationally support this are our academic partners at UC. So UCSF has an organization, CPR3, that's helping us work on this and sponsor this and build this out. And then Covered California, as one of our public purchasers of health, has also really stepped up and helped us create this. And then we are working with other state professional medical organizations, community-based organizations, health plans, health systems, our other state agency partners, other providers and healthcare delivery systems, including pharmacies. We want to work on all this together and then be able to work with foundations as we see other gaps and as we see these funding threats or service threats. How can we pull together us to strengthen our partnerships, but also maybe work with others to help resource some of the things that we all feel are critical. And you know, I already mentioned academics, but really making sure we're leveraging the rich academic resources in the state of California and other academic health systems. And then really, really importantly, a focus on communications. I think we're doing a lot here and just as a health department really rethinking about communication, because I think that is part of why we are likely here as far as having lost some trust and really having to counter a lot of the myths and disinformation out there. Next slide. So again, wanting to have these different groups across the different systems work together to support sharing of science and evidence, and trying to learn from trusted experts outside of any one organization. Again, whether it has to do with what are the implementation issues, what are the questions you're hearing from your patients or your communities, how do we work together to leverage each other's assets and resources as we all get reduced resources and reduce any duplicative work, and really think innovatively about what is this all going to look like, you know, moving forward, and really, again, just formalizing, building our networks and partnerships to solve the public health challenges in our communities. And this is largely modeled after something called the Common Health Coalition that is actually a national organization. I think a few sessions ago, I presented some of their work on showing the impact of public health cuts on healthcare, and they also have a similar model of really bringing together different organizations nationally that touch a lot of those different sectors that we're doing here at a state level. So we'll be coordinating closely with the Common Health Coalition as well. Next slide. It has been top of mind because it is one of the first areas of compromise and something we were losing some vaccine confidence in over time to begin with, that our first area in this FACT coalition we're going to be focusing on is vaccines. So everything from acceptance and uptake, working with both the immunization registry we have and all the health plans to look at where their lowest coverage rates are and really learn share best practices on what are the reasons for low acceptance and uptake, what are the main myths people are hearing, what information do your patients need to make the decisions that they are going to make about their families, and also what are the access barriers. We will certainly be starting to think about and look at as a state, and then working with partners about supply chain and logistics if we lose, for example, the Vaccines for Children resource. And then, of course, making sure as we update policies, which I'll be talking about soon too, or regulation or reimbursement in the state of California, how do we make sure people know about that? Again, help us learn about any challenges with implementation or confusion around that. So these are all kind of different areas we are working to address together in this coalition. Next slide. So we've only had one larger meeting, and we're still kind of working on some different work groups related to this as far as community engagement and communications and even some of the operational implementation issues. But if you are interested, or your organization is, this is a URL to let us know of your interest and to sort of sign up. And we are hoping to have another large meeting, in the coming weeks, hopefully sometime in November, where we'll be able to share any updates on both what's happening here at the state level, but also work we're trying to do together. Next slide. So shifting gears to what have we done in the sort of policy and requirement space in California. On September 17th, AB 144 was a new law that was signed into enactment, where we were able to, while we had seen the compromise and concerns about the Advisory Committee on Immunization Practices, and we were concerned knowing that the Affordable Care Act points to that, but also a lot of our state laws pointed to the ACIP for requirements or recommendations for vaccines. We actually updated our laws to basically remove the ACIP from our requirements beyond what was already in place on January 1st of 2025, and that we as a state health department can issue updates as needed to vaccine recommendations based on new evidence. And again, we are as much as possible really trying to point to other national credible professional organizations, and I'll talk more about which specific ones, or other federal actions that may be compromising what we see as evidence and science-based health recommendations. This law actually requires California regulated health plans to require these immunizations and services. And then we also were able to update some liability protection for those who are administering vaccines as well. Next slide. So all of our updates related to this law and as required by this law are going to be on this new webpage, Public Health for All. And so this is where some of the information I'm going to share with you is also posted, and where we will continue to provide updates as we make any, as far as what is required, what is recommended and required in California for health insurers in California. Next slide. So one of the first sort of products that actually we were able to issue at the same time as this new law being enacted was a combined respiratory virus vaccine recommendations that we worked on with our West Coast Health Alliance partners. So these are the same recommendations across all of the 4 states in the West Coast. And I want to emphasize these are based on American Academy of Pediatrics for kids, American Academy of Family Practice for adults, and then ACOG for pregnancy. So you can see here essentially, I think most of this you generally know, but we encourage everyone 6 months of age and older to continue to get flu vaccines. And then for COVID-19 specifically, we highlight the risk-based strategy here, both for children and adults, so who are the highest risk groups, but we also, really importantly, all who choose protection for themselves, including it might be, living in a household with others that are at higher risk for serious illness. We want everyone who wants to choose protection to be able to get that access. So that is part of what we agreed upon, again, on all these states, and again, based on national recommendations. And then the RSV recommendations are here as well, which are also aligned with the other national recommendations. And I'll say the RSV recommendations are completely aligned with ACIP. And in the end, the ACIP recommendations are not vastly different than what is here, but we weren't sure what those recommendations were going to be when we were issuing these, and we really, again, wanted to base it based on evidence that was presented at the earlier ACIP meetings when it was still intact, and based on what other national professional organizations were recommending. Next slide. Similarly, we have posted to and are pointing to the National American Academy of Pediatrics as far as the immunization schedule for kids. So this, and I think it's also important to remind people that the AAP actually did routine immunization schedules for kids before the ACIP was ever created. So it is absolutely, a really important organization that continues to look at the evidence behind vaccine recommendations and that we will continue to trust here in California. So we are really pointing to their schedule as what we are recommending here in California. That again has to be covered as well for reimbursement. Next slide. Similarly, we're pointing to the AAFP immunization schedule for other routine adult immunizations. Next slide. And before I start talking about this, I'll mention, we are aware that the Infectious Disease Society of America also just came out with some recommendations. So we're looking at that, and we'll be likely talking to our West Coast Health Alliance partners about that as well. And there are a few more not as routine immunization recommendations that we'll be kind of adding and updating on here as well, especially if any of those change at the federal level. It's also important, we just want you to know that this law also, again, made sure that pharmacists can independently initiate and administer any immunizations that are either recommended before January 1st or currently recommended by CDPH. And the existing law already had pharmacy scope of practice to be 3 years of age or older. And then again, this is really aligning coverage requirements for any commercial plans to follow the state public health department recommendations. And our law already, again, provided pharmacists with the authority to administer vaccines pursuant to a protocol with prescriber. And there's no documentation needed. I think another question that comes up a lot is when the ACIP is talking about shared clinical decision making. I think actually you are not the audience to explain this to necessarily, but all of you do that every single day as you're providing services to your patients. You are talking about, what are the pros and cons, what are the risks and benefits, and providing them that information and having shared clinical decision making. There is no requirement that I'm aware of for federal, and certainly not the state, to document that shared clinical decision making. That is routine clinical practice. Next slide. And then there's a few of the provider liability protections to mention here as well, that persons prescribing, dispensing, ordering, furnishing, or administering vaccines are protected from liability for injury if they're given in accordance with these recommendations that are posted on our Public Health for All site, and or if they're given as part of a public health outreach program. This will sunset in 2030 and certainly may be reassessed over time as well. There have been some concerns again about federal liability programs potentially going away. Next slide. These are some of the exceptions as far as who do these health plan coverage requirements not apply to, but any health plan regulated here in California. So it's really most California residents. Next slide. And then I'll try to fly through a few other quick respiratory virus updates. Next slide. We have just launched a healthcare professionals respiratory virus hub that we're really excited about. So the link will be on these slides that you've downloaded. And we hope this is really going to help you meet your needs for information related to flu, COVID, and RSV. And many of you may have noted during the federal shutdown that some of the federal sites are not getting updated, but we are continuing to update this here for California. We have this little meter kind of looking at levels in California as far as respiratory viruses. And then you can see in here on the link to that, and you can sign up for updates as well on this website. Next slide. And this site will have, not only like what's happening as far as surveillance in California, but, buttons and links for what's the latest with vaccines, testing and treatments, another resources library. We also have a button for our local health department partners as well. So please check out this new site. If you have feedback, let us know as well. All of our health advisories will also be linked here. So we're hoping this will be a good one-stop shop for all of when you are looking for information you need as a healthcare provider related to respiratory viruses in California. Next slide. And then I briefly mentioned that HCPAC was actually terminated earlier this year. You may remember, but just as a quick reminder, in January of 2025, CDPH actually did issue some work exclusion guidance for healthcare personnel, essentially saying that for all respiratory viral infections, regardless of whether testing is performed, and healthcare workers should stay at home for at least 3 days since symptom onset and 24 hours without a fever, and then to wear a face mask for source control for at least 10 days after symptom onset or positive test. And this was largely based on some interim proposals that were happening at HCPAC nationally. And it said interim in January because the hope was that HCPAC would come up with some federal guidance, and now that is not happening. Next slide. Oh, I think I took it out, but but for you all to know, I believe SHEA and APIC are actually going to put together kind of a separate healthcare infection prevention advisory group to help come up with these national recommendations. So here in California, those recommendations will stay, and then if there's a different national recommendation, that will get updated. We're working with our West Coast Health Alliance partners as well to just update those guidances and align those for this season. And then we did issue a health advisory on October 14th. So if you haven't seen that, you can also click on the link here for that to see just some of our key information there. Next slide. And then I showed this last time, but just, some links to our key dashboards related to respiratory virus surveillance and also our projections on hospitalizations at CalCut. Next slide. And then lastly, I just wanted to touch on this because it's interesting that it hasn't gotten as much coverage as we thought it might, but we have seen Mpox Clade 1 locally acquired here in California. Next slide. So just a reminder that there are two types or two clades of Mpox virus, and what we saw in 2022 when we had the first outbreak and we started seeing Mpox in general circulating in the US and in California was Clade 2. So that's what started in 2022. And then Clade 1 has been increasing in Central and Eastern Africa, and there's been an outbreak since last year in about 13 countries in Central and Eastern Africa. There's been some suspected community spread in the Middle East as well, and then a few other countries that had limited local spread. But prior to the last few weeks, there were only travel-related US cases here in the United States, and there had been 2 in California prior to recent cases. And then there are several, actually in addition to Spain and Netherlands, I think there's a couple more that have just been announced that have also been reporting locally acquired cases. So this is no longer just circulating in Central and Eastern Africa, but we're really starting to see this spread globally as well. Next slide. So we had 3 Clade 1b Mpox cases reported in Southern California as of last week. They were in a similar geographic region, but the individual cases did not have international travel themselves. They did not report any sexual contact and no contact with one another. There's no link across these 3 cases with each other. All 3 of them were hospitalized. All of them were unvaccinated. They're all isolating at home. There's been extensive public health investigation, including contact tracing and symptom monitoring. No secondary cases have been identified to date, but this does really signify that these are the first locally acquired cases in the United States and just signifies that there is some community transmission. And again, it's vaccine preventable. Next slide. Here's some just key things to keep in mind as far as infection prevention for providers. And, in addition to wearing the appropriate PPE when assessing patients for this, any patients being tested should be advised to isolate at home pending those results. And please notify your local health department immediately if you are suspecting Clade 1 Mpox. And we can help make sure through the local health department lab network that gets tested. And we're doing some enhanced surveillance around this as well. So we will be continuing to monitor this closely, but next slide. wanted to, again, make sure that you all remind your patients that Mpox vaccine is still available. JYNNEOS vaccine is available. And in addition to the prior recommendations of gay, bisexual, or other men who have sex with men, as far as getting up to date and making sure they get 2 doses of vaccine, also HIV infected, they're certainly at higher risk for hospitalization and more serious disease if immunocompromised. And then also if planning to travel to sub-Saharan Africa, the Middle East, or a country that has a clade 1 Mpox outbreak or other reasons, you really want to remind your patients to get up to date on a vaccination. And the other indications have not changed, but just wanting to make sure you all get that information out. We've been working with other providers, specifically HIV and other MSM providers as well, to get the word out, but we just want people to know that clade 1 is here, it's circulating, and people should get up to date on their vaccine. There was some concern early on that maybe it could be more serious and or more transmittable. The more recent data does not necessarily signify that, and it is a different clade. So we, again, just want to remind people this is something that we want people to get up to date on vaccines and to do other preventive measures. Next slide. Okay, with that, I will turn it over to Dr. Nguyen to talk about some other emerging areas. Thank you.
Great, thanks, Dr. Pun. And we recognize that was a lot because a lot is going on in public health. I aim to wrap up around 12:45, just so there's enough time for Q&A. There's a lot of content I have, and so it'll be in the slides, but I'll try to go a little quickly. So moving away from more the infectious disease space to other areas of public health, I was going to give updates on other emerging areas in public health, maybe in the forefront of folks' minds in some domains is the government shutdown. You can advance slide. So CDPH administers WIC. We don't administer CalFresh, which is the California Department of Social Services, but as you can imagine, the impacts of cutting access to food benefits greatly impacts our communities, your patients, and so I do mention it here. So for WIC, we do have estimated funding to remain fully operational through the end of November 30th, barring any unexpected changes at the federal level. Those estimates are always subject to change given any number of factors, but our current projection is November 30th. CalFresh, this is just right around the corner when benefits will start being delayed, and so we've already seen folks trying to newly enroll in CalFresh having challenges in the month of October. The federal government has not funded CalFresh or SNAP, as it is called federally, formerly food stamps, beyond November 1st. So folks will not have those food benefits starting just this Saturday. And Governor Newsom just deployed the National Guard to support food banks. This is more operational support to ensure community members and our patients are getting food, which is so core to their health and their well-being. Advanced slide, please. Another area to mention is in public health, we actually had our main core of chronic disease prevention funding end with the HR 1 that was signed July 1st. Advanced slide, please. And so those may or may not have been tracking. This is SNAP Ed funding. It was part of the Farm Bill, and HR 1 that was signed in July, also known as the Big Beautiful Bill, ended funding for this program effective just this past October. Any remaining funds are just unspent funds from the prior federal fiscal year. And so for situational awareness, again, this is the largest and mainstay funding for chronic disease prevention in the state. For the last 20 years, this has helped promote healthy eating, physical activity, a lot of upstream policy systems and environmental change to promote health. It ended up being about $132 million lost to California, and California accounting for about a quarter of the federal budget. And of course, many staff across the state lost their jobs as a result of this. Next slide, please. Moving on to clinically related guidance in the non-communicable disease space. So earlier this year in spring, with that first round of CDC layoffs, we also saw the dismissal of the Committee on Heritable Disorders in Newborn and Children. And so this committee devises the RUSP, which is the Recommended Uniform Screening Program. That list has heritable and metabolic disorders that then informs newborn screening panels across the country. And CDPH, we operate our newborn screening program. And so other entities like the American Academy of Medical Genetics is stepping in to give science and evidence-based recommendations on what should be included in newborn screening going forward. We also have seen publicly Secretary of Health and Human Services federally has indicated his desire to dismiss USPSTF, which I know you all depend on for recommendations for preventative screening and care. And so that's an area that we're watching closely in case public health may need to step in and work with our various health association partners to be clear about what is evidence-based preventative guidance. There's also concerning directions coming out from federal authorities like the FDA and others. We've seen statements about autism and Tylenol, about SSRIs and the use in pregnancy, and just recognizing that in some areas we've made public statements, especially in the autism space, to recognize the complexity of autism, that there's no single causative agent or source, the safety of proper use of Tylenol in pregnancy. And so recognizing that we really do lean on our clinical partners and associations around clinical guidance, and being thoughtful of when CDPH can also add and be value added to clarify what is science-based and what is evidence-based recommendations for patient communities. And so there will be times when CDPH will partner with other associations to make it clear to the public what is safe and what isn't, and recognizing that we can't swing at every pitch, but we do monitor various statements and how it may undermine trust in science and medicine and public health. We recognize there's also been statements to question the safety and effectiveness of community water fluoridation, which the CDC, up until it got pulled off their website, was heralding as one of the greatest public health interventions in the 21st century. And so our Office of Oral Health has done some work to help discuss and give sort of background knowledge to the safety behind community water fluoridation. In the interest of time, I'm going to go pretty quickly past the MAHA report. There's a lot of content in here. I just wanted to relay at a high level what it is, in case folks have been hearing what's contained in it, where it's aligned with public health perspective and where it might deviate. And so as a bit of background, this was a commission that was launched earlier this year. In May, they put out an assessment report. The first focus is on childhood chronic disease. There are a number of areas of alignment within that assessment report, a number of areas of deviation from what CDPH and public health would take. Some of that then ultimately manifested in this September report, which came out, and this was actually the strategy report. So the first report was just more like a problem statement of childhood chronic disease, and where they thought there might be underlying root causes for chronic diseases in children. So I'm gonna, you can advance slide. And then early next year is meant to be policy implementation of those strategies. So there were over 100 proposed strategies across research, regulation, education, and infrastructure. There weren't a lot of details on exactly how these plans or strategies would be executed, but it crossed areas of research about payment and incentives for food programs and healthcare programs. There was mention about increased public awareness of and having campaigns around nutrition and screen time and mental health. And also there was mention of the restructuring, which Dr. Khan mentioned a little bit about how much of the CDC has been eliminated, and then a proposal to reorganize under this administration for Healthy America. Go ahead and advance. So there are areas of alignment around a whole person approach, the importance of healthy foods in environmental settings where people, school, where people are learning, playing, working, sort of the social drivers of health, and how food can be part of that. You can go ahead and advance. And again, I'll go through the MAHA pretty quickly, but the content is there for you. Again, areas of alignment on the interest in looking at nutrition, the importance of mental health and school-based interventions. There's mention of the importance of environmental health and also the connection with oral health. Next slide. So there are a number of areas of concern, and just to start off with, the composition of the MAHA Commission does have a number of individuals who've very publicly questioned the science behind and safety behind measures like vaccines and fluoridation. Elements of the report sort of miscited data, sometimes cited studies that did not exist, and this then calls into question some of the strategies and the recommendations that came from that initial report earlier this year. And so there is mention of the importance of scientific rigor, but then points to alternative methodologies rather than sort of more standard peer-reviewed peer-reviewed process for assessing data. Again, I've mentioned a little bit about vaccines and community water fluoridation. Next slide. Dr. Pan mentioned this a little bit, but also there is explicit intent to integrate data and combine data sources that in the past were purposely kept separate for the purposes of preventing the identification of individuals. So this ultimately underlines people's faith and trust in what happens when they do share data in healthcare settings or in public health settings. There's explicit mention about over-medicalization, which is related to sort of FDA statements about SSRIs and the safety in pregnancy without really regard to the morbidity and the mortality related to not adequately treating mental health conditions in the perinatal setting. There's no mention really of the underlying drivers of health disparities, of which a lot of that is structural disparities, social drivers of health, racism, and poverty. And so that approach is not really seen in the MAHA report. And then there's inherent funding contradictions that despite an emphasis on chronic disease prevention, we're also seeing cuts to the funding to the staff who would primarily do this work in the administration. Next slide. You can go ahead and advance. And just wanted to mention a couple hopeful paths forward in the public health space of areas we are working and taking leadership, one of which is in the healthy food and nutrition space. The governor signed an executive order earlier this year directing state government to really take a closer look at how nutrition and ultra-processed foods was contributing to health outcomes. It was a huge win in the public health space to have AB 1264 signed, which is the first of the nation definition of ultra-processed food, with an ultimate goal of decreasing access to UPFs and its accessibility in school settings. Go ahead and advance. So in the interest of time, I might just like thumb through these. And so this is about the UPF bill. Some of those definitions will be further defined in regulations and give time for schools to phase out these UPFs. Advance, please. And this is just for reference. UPF, the definition is statutorily defined as containing one or more cosmetic additives and being high in these nutritive components that are linked to health harms. We also added a piece on non-nutritive sweeteners, so that's things like sucralose and stevia. Again, in just of time, I'm just going to move beyond this, but it's there for your reference. And so just other hopeful paths forward in public health, we are seeing an infusion of funding from the Behavioral Health Services Act that passed as part of PrEP 1. So that's about $150 million to CDPH to really think about behavioral health prevention. We're starting to see a turning of the curve on overdose deaths, as you can see with our latest data from 2022. We're working towards banning intoxicating hemp that can be easily sold on shelves with regulations. And then just a quick note on Kratom and 7-OH to Claire, and you can go ahead and advance. There's been a lot of confusion because of it's been so readily available in retail and online spaces. we are putting out a lot of content to clarify that it is not legal to sell or manufacture kratom or 7-OH. Part of the confusion is really, and you can go ahead and advance. And this is, it has both opioid and stimulant effects. I think clinicians have probably heard of this, or maybe even had to call poison control for your patients who have been exposed. But some of the confusion comes from the fact that it is not illegal to consume or possess it, but it's certainly illegal to sell or manufacture. So public health and environmental health departments are trying to enforce that to the extent we can. We're going to be issuing a lot of different content to help reinforce that. One of which is a health advisory to clinicians to help educate on what kratom and 7-OH is. And with that, I think I might have one more slide. You can go ahead and advance. Oh, no, there's more. Just more areas where we're working on Black birth equity, silicosis as a reportable condition, also about to put out a KHAN that clinicians will be seeing. Just this week, we're having, I think it might be even today, is a firearm violence convening that we're hosting and a roadmap that we published, which has been years in the making. And we've published guidance on collecting data on SOGI and improving our work around collecting more granular race and ethnicity data. Okay, one more slide. And this is just to end on a message that we give to our teams and think of relevant to you all as well, as how hard it can be through such changing and uncertain times. It seems like a lot is being lost in terms of funding and teams and work. And I found this helpful when I was a primary care doctor in terms of the humility of what we can do for our patients. And yet it is all towards a collective good. And the quote is, ours is not the task of fixing the entire world all at once, but of stretching out to mend the part of the world that is within our reach. So thank you for all that you do for your patients, for our communities, and stretching to mend the pieces that are within your reach.
Well, thank you so very much to Drs. Pond and Nguyen. There's so much here, and we appreciate all the work you're doing. And also, I think the information where we can go to make sure that we stay up to date and learn as all of these things are progressing and changing. So thanks so very, very much. So there's a few questions that have come through around vaccines. One is a logistical question around, is there a protocol for children who are under 3 to be able to be vaccinated through a pharmacist?
Yeah, unfortunately, this is a gap that has been in existence, and I know our team has been talking with pharmacists. I think, and I think kids under 3 still need to find sort of either through their provider, or we did actually just provide a few more doses of COVID-19 vaccine for local health departments. You can also contact your local health department to get vaccinated there if you're not able to get it through your provider. I think there's various combinations of the logistics and comfort level of pharmacists for kids under 3. So that's been prior to all the recent federal changes. That's always been kind of the cutoff here in California and in many other states as well.
Thank you. Do you have information about which vaccines are becoming the ones not accepted or refused? Is there a bit of a trend that you're able to share?
We do have other sort of trends that, and follow-up we can share. I think, there's a real variety of what's happening. I think some families are delaying vaccines or spreading them out as well. Certainly I think when there's pockets of unvaccinated populations, sometimes they're not doing any of them. And then there are some that are trying to prioritize. I don't have at my fingertips that, but we're happy to bring that back in the future. grand rounds, and/or, I think that is something that with this FACT coalition, I think we really want to work with partners and specifically for different health plans or insurers to kind of look at what are those trends and are there specific vaccines more than others. I will say anecdotally, and I'm sure many of you as frontline providers are seeing this as well, but I think one of my other big concerns is just hearing from my primary care pediatric husband about just the things his patients are telling him that they're hearing on TikTok and other things, and that they're relying on those more than his advice, and that overall is really concerning. And not just about vaccines, about all kinds of interesting, sort of unusual health advice out there.
Oh yes, I'm noticing that too in my practice for sure. I think I remember back when we had the big outbreak with measles, that there was conversations around really trying to have the data in local communities, even at the level of schools, where parents could be informed when the vaccine rates kind of fell below that herd immunity. And we did see that there was increase in acceptance when the data got really very real about the risk. So I think that as that coalition gets going, that'll be some really good and important conversations to start to have. But back to your other issue around, TikTok and where our patients and their families are getting their information. What are your thoughts about how we increase the trust in the medical community and with our patients?
Yeah, I think we have a lot of work together. And one quick plug just back on the schools topic is I believe the URL is shotsforschools.org, but that is where families can look up your school's vaccination rates. So, agree. I think that's a great tool for people to know about. I really think we, in many areas, but certainly related to health and public health, need to rethink how we are communicating in general. And I will say, traditionally in public health, a lot of our communications have been, do a press release, plus minus a health advisory. We're increasingly using social media, but getting the feedback loop on what are people hearing, what are their questions, making it all more digestible, and really leveraging and using social media, because more people and I've heard other even public health practitioners talk about, penetrating the media, but I think they mean, some of the echo chambers of, our more traditional newspaper outlets that may have a social, like website and or social media presence, but is really different than where, again, people are getting their information. So yeah, we're working on something. We're actually just trying to start what I'm calling Project Stethoscope with a partner, your local epidemiologist, to really listen better and hear back from the community, do some social media listening. But also part of this FACT coalition is really working on our messenger network and really, again, not only getting good and consistent information out in hopefully a way that is useful, but getting, again, input back in on how is that landing. This is the question I still have that wasn't answered. How can our partners, adapt the information and messages because our partners are the ones that are really trusted. And if you can have those kind of trusted messengers and build the network, that is kind of my hope on this. But I think, there are so many unanswered questions about how we move the dial on this. But it does feel like others have moved the dial in the opposite direction, and we need to figure out how to counter that.
Yeah, thank you. I agree with you. I think there is going to be a lot of different angles that we'll need to use, and I love the conversation. A logistical question around Mpox. Somebody was asking about the recommendations for the dose, but also wanting to know how much of the eligible population has been vaccinated, if we have any sense of that.
I think our team does. I don't have it off the top of my head. It is lower than we would like, though, I will say. I mean, especially that second dose. I think there are many people in high-risk populations who've gotten the first dose, but then never, went around to get the second dose. So, but happy to report back on that if that's of interest later.
Great. And do you have a location someone could go to find the dose recommendation?
Yes, on our CDPH website, we do have an Mpox page, and then there's both any trends that we do have as far as vaccine coverage, but also recommendations for doses and who we recommend it for, et cetera.
Wonderful. I think that the other piece that's on a lot of people's minds that you touched on in the presentation is how can we really mitigate the harm that's coming from HR1? You know, the cuts that have already started, but also what we know is coming related to Medicaid and the SNAP and the CalFresh program.
Yeah, this is a really, really huge area and impact. I think one more of a resource on how to stay up to date on what are those impacts and how the state is responding to that is our overarching umbrella agency, the California Health and Human Services website. We're kind of producing webinars periodically. There was another one yesterday about sort of the recent impacts and anticipating impacts of SNAP. We did one actually around the time when we issued the law I described today. So that's a good place to stay tuned on what's happening. Yeah, it's a really big challenge given those cuts that are happening federally and then having our own kind of state deficits. So I think we're all going to need to be creative and innovative and really working across different sectors to figure out how to address some of these really challenging gaps.
Absolutely. I know that that is something that California Medical Association is actively in conversation around. So I just want to close. We are out of time. And really just thank you both for being here and sharing all of your expertise. Thanks to everyone for joining and listening and taking the time to learn. As I mentioned, you'll be receiving the survey around 5 o'clock today, and complete that at your convenience to test your attendance. And then your certificate will be mailed to you within a week. Thank you so very much, everyone, and have a wonderful day.
Thank you.